Hi there. My name is Dr. Eric Zhou, and I am an assistant professor at Harvard Medical School and a clinical psychologist at the Dana-Farber Cancer Institute. I'm pleased to be able to talk with you today about better sleep for cancer survivors. My goals today are first to be able to convince you that sleep is something that matters for cancer survivors. Next, to help you understand your sleep, and then to encourage you to be able to implement behavioral changes to your sleep that can improve it as well as your overall health. Now, regardless of where you go in the news, you're likely to come across article after article after article about sleep and sleep health. And this is in part driven by an increasing number of Americans who are struggling with sleep. So for example, in the CDC data, we see that there are a sizable number of American adults who are sleeping less than 7 hours per night on average. As a result of this and other data, the federal government has launched a Healthy People campaign in which sleep health is one of the core domains that they want to improve among citizens in this country. And that's because we've started to see more and more just how much sleep matters for our health. Now, in this Reader's Digest title that says America's sleep crisis is making us sick, fat, and stupid, you might think, well, this might just be a clickbait title that really exaggerates the reality. There's another article that says, perhaps even worse, that insufficient sleep makes us fat, stupid, and dead. And now you're thinking, well, this can't possibly be real. Well, if we examine the 10 leading causes of death among American adults, and then we look at how sleep relates. So for example, short sleep and hypertension. From this data, we saw that over an 8 to 10 year follow-up period, short sleepers were associated with a significantly increased risk of hypertension, about 2.1 times, even after controlling for things that lead to hypertension like obesity and diabetes. What about weight gain? In another study, what they looked at were almost 70,000 women who participated in a nurse's health study. And after adjusting for their age, their baseline body mass index, their level of physical activity, and their diet, those who were getting less sleep were 32% more likely to gain 15 kilograms or more during the study follow-up period. For motor vehicle accidents, another study showed that their estimate was that about 22% of accidents could be attributed to sleepiness. And this, as well as study after study after study, shows that sleep has a significant and deleterious effect on our health. In fact, if we come back to that top 10 causes of mortality among adults in the United States, we see that many of these issues are either worsened by, or perhaps even sometimes caused by, sleep-related disturbances. Now you're thinking, well, what about for cancer populations? In this beautifully done study out of Stanford University, what researchers looked at were advanced breast cancer patients. The blue curve shows women who were sleeping well. This was defined by something called sleep efficiency, which is a ratio of the amount of time that they spent sleeping divided by the amount of time they spent in bed. And if you see on this chart, the blue, or the good sleepers, were much more likely to survive over the 100-month study follow-up period than the poor sleepers who are in the red part of this graph. And their conclusions suggested that an improvement in sleep efficiency by something as small as 10% among poor sleepers, or those women with a sleep efficiency under 85%, that this could lead to a 32% increase in survival time. It's remarkable how important sleep is for cancer patients and survivors. Now, the unfortunate reality for many of us is we see that sleep is completely trivialized. If you happen to be in the New York, New England area, you may have seen a shop called Insomnia Cookies. And I like to say to people, well, insomnia just feels like it's something that's not significant, right? But No one would ever name the shop cancer cookies. That just sounds completely absurd. And yet, hopefully, I've showed you that poor sleep is actually associated with significant health outcomes if we don't address it. Now, I'm going to focus a lot of our attention during the conversation today on one of the most common sleep disturbances for cancer survivors. This is insomnia disorder. And this is the diagnostic criteria, but I've highlighted in yellow the parts that are most relevant for those who are watching. Really, what insomnia disorder describes is somebody who has struggled falling asleep, staying asleep, or waking too early, and that this happens at least 3 nights a week for 3 months or more, meaning that this threshold to cross in order to be a person with insomnia is not as significant as many people assume. Now, insomnia is common with regards to those with cancer. In this wonderful study out of Canada, what researchers did was they followed folks right after diagnosis, before treatment started, for a period of 1.5 years. And you see that during this period, the percent of patients with insomnia might have gotten lower over the course of that 1.5 years, but it absolutely does not disappear. In fact, at 18 months, we're seeing that more than 1 in 4 patients continues to struggle with insomnia, which is often something that has been forgotten because we assume right after diagnosis, sleep is poor, but then this just goes away. And hopefully this evidence compels you to understand that it does not. And if you're struggling, you're not alone. I wish to clarify, though, that because sleep is such a vast issue, that many people tend to mix up what sleep disorders are. And in fact, this list is not a comprehensive list, are sleep disorders that are not insomnia, but might cause you to have bad sleep. The one that I want to spend just a moment on is sleep apnea, because for somewhere between 5 and 10% of American adults, it is a sleep disorder that they struggle with. And this describes, we're talking about obstructive sleep apnea, a blockage of your air passageways when you sleep that prevents you from being able to breathe, essentially, over the course of the night in these short bursts. Now, there is overlap between insomnia and sleep apnea, as you see in this wonderful figure here. So, for example, both insomnia and sleep apnea might present with symptoms like frequent awakenings, difficulty falling asleep, fatigue, etc., which means if you've had a sleep study done before and been diagnosed with sleep apnea, it doesn't mean that you don't have insomnia. And in fact, sleep apnea and insomnia are treated with different approaches. If we're talking about insomnia, though, and you're struggling with insomnia, and you go to your medical team, well, what might happen when you tell your doctor about your sleep issues? Is it medications that's prescribed? Is it some form of therapy? Well, in practice, what we see is about 1 in 5 cancer patients are prescribed hypnotic medications. This is something which is a chronic medication that's prescribed. It's not something that's given to you perhaps just after surgery to help you sleep. But this is something that for more than half of those patients in this particular study, what they saw was that they were taking and being prescribed this hypnotic medication for their sleep consistently. Unfortunately, we know now that the prescription of medication to treat insomnia is not and should not be the first approach taken. The American College of Physicians in 2016 published a clinical practice guideline, and I highlight for you their first recommendation, which is that the American College of Physicians recommends all adult patients receive something called cognitive behavioral therapy for insomnia, or as it's commonly abbreviated, CBTI, as the initial treatment for chronic insomnia disorder. And I emphasize the word initial, not after medication no longer works, or you don't want to pay for that copay, or you're dealing with side effects of something to do with a prescription. This is the first treatment that you should initiate for your insomnia. People ask, well, what are the side effects of this compared to, say, prescription medication? And for cognitive behavioral therapy for insomnia, the most significant one is a short period, about 1 to 2 weeks, of sleepiness during the initial phase of treatment. Pharmacotherapy, we've seen in multiple studies that there are considerations that are not desirable as a side effect. In fact, what I like to tell patients is for a medication that helps you sleep, it doesn't come for free. There is generally something that comes with it that you may want to consider in balancing this decision-making process. Now, you might think, what about things like melatonin that we can buy just down the street at the pharmacy or at the grocery store? Because these products are not FDA regulated, there are some concerns. For example, for melatonin in this study that was published out of Canada a couple of years ago, what they found in their results was that melatonin content was highly variable between brands and even within the same brand, different lots within that brand. And that serotonin was found in a significant number of the melatonin that was sold to you over the counter. Also, it's important to note that melatonin is not a drug that has been advised by the American Academy of Sleep Medicine for insomnia. It is, however, something that we use in clinic if we're treating things like a circadian phase disorder or jet lag disorder, for example, but not insomnia like it's commonly used in the community. With that being said, I find that the use of both prescribed and over-the-counter medications for insomnia doesn't address the core of the problem. By that, I mean, let's just say you're taking a prescription for your sleep. Well, what happens if you forget it when you go away on vacation? It's very likely that that insomnia might come back because you don't have that medication on board anymore. And that, to me, is the biggest challenge for the use of anything other than behavioral approaches, because it does not fix the real problem. Now, what CBTI does is it fixes the core of the problem, and how this can be explained is something called the 3P model. I want you to understand your insomnia. In this case, if you look at this graph, what I want you to look at and see here is the scale on the Y, or the vertical axis, is how bad somebody's sleep disturbance is. And we'll just draw an arbitrary point at 50 and say everybody above that has insomnia, and below it's just a little bit of bad sleep, but not true insomnia. Well, when you see going left to right on your screen, on the X or horizontal axis, is somebody's insomnia from baseline, they don't have any sleep issues, to the acute phase of insomnia, to the early stage of insomnia, to chronic insomnia over time. And what you see first in the blue are their predisposing factors. These are the things that we bring to the table, things like our sex, how old we are, things we can't change. And what you will see is that these factors that are our predisposing factors, it does not change over time. These are the things that perhaps make some of us more likely to have insomnia than others. Well, what's next? The green highlights something called precipitating factors. These are the things that kick you over that threshold and cause your insomnia to develop. And for many folks who have been diagnosed with cancer, many parts of the cancer process are things that are likely to, by itself or added together, precipitate their insomnia. So for example, finding out that you have cancer, having to be in the hospital for multiple days, weeks, or months because of your treatment or after treatment, feeling fatigued after radiation therapy, or the side effects of the medications that you're taking, or perhaps for some, the hot flashes that they experience as they're on adjuvant therapies. All of these things could kick you up over that threshold and cause your insomnia to start. But what I want to draw your attention to is over time, these things start to become less of a significant issue. I'd imagine that for you, if you had, say, incredible stress and an inability to sleep the night that you found out that you had cancer, that this is something that a year, 2 years, 3 years after your diagnosis, you certainly never forgot about that night, but you absolutely aren't as impacted 2, 3 years later as you were that night. Yet your insomnia remains. Why is that? Well, this is what is called the perpetuating factor. These are the things that you continue to do to try to make up for bad sleep that then cause your insomnia to last. These are things like sleep effort, excessive time in bed, irregular sleep-wake schedules, etc. And what you will see is that these are the things that keep you above that insomnia threshold. And this is what CBTI, or cognitive behavioral therapy for insomnia, tries to fix. Now, when we think about CBTI, I need to clarify this is not CBT for, say, depression or an anxiety disorder. And you'll certainly not be asked to sit on a couch and tell somebody about the relationship you have with your mother. This is very different than those types of therapy that you might have seen on the media or might have even had experience with yourself. In fact, CBTI is a very specific toolkit just designed to treat your insomnia and nothing else. In this case, the original approach is about 6 to 8 sessions over a 6-month period, and there have been recent efforts to distill that to something that's called brief behavioral therapy for insomnia, which is about 4 sessions over a 2-month period, which means this course of treatment is not long. Even if you've had insomnia for decades, the course of treatment, I repeat, is not long. The key ingredients. First is sleep restriction, or matching the amount of time that you spend in bed to the amount of time that you actually sleep, and not, as we will find out soon, some normative number that the average adult might need. It's about what you need. Second is stimulus control, which is using the bed only for sleep. Third is sleep hygiene, which is improving behaviors that affect sleep. And I want to draw your attention to this because for many of you, you've implemented sleep hygiene strategies like leaving your cell phone out of your bedroom or not drinking coffee after 2 p.m. These are all things that are important to do, of course, but as a treatment by itself, it is very unlikely that sleep hygiene will cure your insomnia, despite the fact that this is what most of the websites that you'll go on, and when you Google, I can't sleep, what do I do, that they'll tell you. Fourth is something that's called cognitive therapy, which is addressing how you think about sleep. And finally, relaxation exercises. The first step to all of this is actually collecting data about your sleep. And I don't mean using a consumer wearable. In fact, these are things that we generally don't use because insomnia is a subjective disorder. And what I mean by that is it's diagnosed by your report of sleep, not because a sleep study told you something or your watch told you something. This is about your experience of sleep. These are 2 examples of sleep diaries. You can either color in when you sleep or write down with regards to when you sleep. This is what we use in the vast majority of patients that I see in clinic. Because again, I repeat, I want to understand what your experience of sleep is and not necessarily what a device tells you it looks like. The first piece of CBTI that I mentioned earlier is this thing called sleep restriction, which is simply understanding that we shouldn't spend more time in bed than the actual amount of sleep that we need. And the reason for this is because you want to start to accumulate something called sleep debt during the first phase of treatment. Sleep debt is something that we accumulate as we are awake. And I tell folks, well, think about when you might have gone to an airport. Let's just say you had a 6 a.m. flight and you had to wake up at 3 o'clock to make sure that you packed all your toiletries and you had to take the ride share to the airport, and it's 5 o'clock and you're sitting there at the gate, barely able to keep your eyes open, and you're looking like that. That's sleep debt hitting you over the head. That's the phenomenon, the feeling that I want poor sleepers to have during a specific time window. Meaning, I want those who say they can't fall asleep or they can't stay asleep, like they wake up in the middle of the night and they are up for hours. I want those patients to see that with enough sleep debt, because of sleep restriction, your body, well, it will sleep as long as we control this opportunity and use sleep debt to our advantage. Now, if we can't do sleep restriction the way that we naturally or normally wish to do in CBTI, something that you can implement in day-to-day practice is what I view as sleep restriction Lite. And this is waking up at the same time every single day, no matter what time you went to bed the night before or how your sleep was the night before. And this is a mistake that many patients with insomnia make. What they do is, let's just say on one day, they're up a lot in the middle of the night, they don't get good sleep. Well, what's natural for them is the next morning, if they don't have to wake up for work or for school or whatnot, they stay in bed longer on like a Saturday or Sunday, maybe an hour, 2, 3, even beyond when they wake up during the week to try to catch up on sleep. And by doing that, they've used up their sleep debt, which means that on Sunday night, they're less likely to fall asleep at the time that they want. And they're back to that cycle during the week where they might not get enough sleep, and on the weekends where they then oversleep. The next piece is stimulus control, which is using the bed only for sleep and nothing else. Now, you might think, well, this is me telling you, well, don't be on your phone in bed, don't read in bed. And these are certainly things that we talk about, because the idea is you want to condition or teach your body that your bed is a place just for sleep and not other activities. But the biggest thing that people with insomnia do in bed is something that's called sleep effort. If you have insomnia, then you know what it feels like to lay down in bed at the beginning or the middle of the night and just wish and pray and hope to fall back to sleep. It's this constant fight or this struggle. And the harder you try to fall asleep, the harder it is, of course, to get to sleep. And so what we ask patients to do then is to get out of bed and to do something that is absolutely distracting them from the fact that they're not sleeping and they really, really want to sleep. Because again, the harder you try to sleep, the less likely you are to sleep. This in combination with the sleep restriction, because you're accumulating sleep debt over the course of about the first week, what will happen for patients is they'll see that no matter how worried they are about not sleeping, that by the end of that first week, they have so much sleep debt that their body essentially shuts them down and allows them to sleep during a restricted time window. Next is sleep hygiene. These are likely things that you have considered, thought of, read about online. So basic things like getting rid of the bedroom clock, because that's just more pressure for you not to sleep. Being more physically active, avoiding things that disturb sleep like caffeine in the evening, having a light snack before bedtime if you're finding that you're waking up hungry, trying to reduce liquid consumption before bed so you don't have to wake up so many times to go to the bathroom, and trying to avoid electronics use, not only because the light exposure is not good, but also because it's really distracting. It's hard to stop being on your phone because somebody posted something or there's a new series that you want to binge. And then fourth is cognitive therapy. Now, these are things that often come up for poor sleepers. They might say to themselves, well, if I don't sleep well tonight, I don't know how I'm going to be able to work tomorrow. Or, oh, this insomnia has got to stop because I've been told by my oncologist I have to sleep well and my cancer might come back if I don't sleep. Or I'm never going to be able to fall asleep with so much to think about and worry about right now. Well, hopefully in the light of day, as we're talking about this, you see that none of these thoughts can help you sleep that night. And if anything, it only adds more pressure to make it harder to sleep. And yet it's really hard to stop these thoughts at 3 o'clock in the morning when you're laying there for the third night in a row not sleeping. Another thing that we do is help people understand that sleep is an individual event. If you recall, I said earlier, we want you to sleep the right amount of time. And that's different for everybody. In fact, if you see on this chart from the National Sleep Foundation, for somebody who's 70, you might need 5.5 hours of sleep. That may well be appropriate for you. You may not be a long sleeper. Now, the average might be somewhere between 7 and 8 hours, but it doesn't mean that that has to be you. What I'd like to say to individuals is, well, for example, your height. You might be an average person with regards to height. Doesn't make you bad or good. It's just who you are. Or you could be tall, or you could be short. But there's a range before there's any concern from, for example, your primary care physician's perspective of, do we need to change anything? And in this situation, we don't have to change anything at all if you sleep 8.5 hours or you sleep 6 hours. Understand that everybody is different. And in this case, I must emphasize that this idea of more sleep is not better sleep. In fact, that's the pitfall, the trap that many patients with insomnia get stuck in, is wanting more sleep to make up for their low quality sleep, when what they really need is the right amount of sleep that's high quality. And why I have this picture up is to remind you that you don't take that approach when it comes to food. I hope that you don't think every meal needs to be you at an all-you-can-eat buffet, eating until you're sick, that that's the right thing to do because it's more food. Most of us don't think that way. And sleep is the same idea. You want the right amount of sleep that's healthy and that's good quality sleep, not just more. Also, during the course of cognitive therapy, I help patients understand that sleep is a very, very significantly, it's a challenging event. It's an event that can be disturbed by so many things, like, for example, medical illness, not just cancer, but if you have the cold or if you have pain, it can absolutely affect your sleep. And you have to make sure that those things are also managed to the best of your ability. Sleep can be affected if your spouse and you get into an argument, if you have young children, if it's hot outside and the AC isn't working, if you're exhausted from work, or heck, even if your favorite football team wins the Super Bowl. That both good and bad things can affect your sleep. And it's important not to place too much blame on your sleep and understand that there are other things going on in life that affect. And the last piece of CBTI are relaxation exercises. Now, there isn't one that you have to do. And what I tell patients is you do the one that you like the most, that you're willing to practice consistently. That's more important than whether you do mindfulness meditation or you do yoga, for example. What's also important to emphasize is that you do not do these exercises with the intention of falling asleep. So I discourage you from, say, you want to fall asleep at 10:30, from starting a mindfulness meditation at 10:15, setting a 15-minute timer and saying, okay, I've got to fall asleep at 10:30 now. That is sleep effort, which we had talked about earlier, and only going to put pressure on you that is the opposite of what you want. You want to do these relaxation exercises because it lowers the level of your physiological and psychological arousal, and it puts you into a stage in which you're more likely to fall asleep. But remember, you should not be doing it because you need to fall asleep when that app timer ends. Now, in terms of how do you do this work? Well, if you hop online, there's a number of good workbooks to walk you through what we've talked about for CBTI. I would argue, though, that you have to be the kind of patient who's incredibly self-motivated. And I know I'm not one of those. I mean, this is like your primary care saying, Jack, you need to lose a few pounds, and you saying, say no more, doc, and come back for your annual physical the next year having lost 40 pounds without any advice whatsoever. Well, if you're that kind of a person, then these workbooks may be great. But for the rest of us who need a little bit of guidance and nudging and pushing and explanation, there are alternatives. So for example, there is an FDA-approved online automated treatment called Somnus that your primary care could write a prescription for, and your insurance will hopefully cover. If you want to find an individual provider, the Society of Behavioral Sleep Medicine has a provider list on their website at behavioralsleep.org. And what you really want in this community-based provider is somebody who specializes in what's called behavioral sleep medicine. That's the umbrella under which CBT for insomnia falls. And remember what I said earlier, it's important that they do this thing and not just general CBT. So our take-home messages today. First, sleep problems are common among adult cancer patients and survivors. They can often be treated effectively without prescribed or over-the-counter medications. And behavioral sleep medicine for insomnia is not standard therapy and requires a specialist. Thank you so much for your time. And if you do have questions, please feel free to email and we can discuss further.